appreciate the opportunity to speak with everyone today. I'm going to start out and talk about shared decision making. You'll see that just from the title, we've intentionally taken start from a starting point of patient-centered care, and I recognize that many in the audience will not necessarily be from our domain as healthcare providers, but as we go through the presentation, you're going to see us, transform, especially when we get to Kim's work of how our interaction has come to be. But this, this kind of a starting point is intentional because really where the shared decision-making literature grew out of is, at least from our perspective, is in the healthcare environment. And that's ultimately what we've brought to this partnership with LFCC and other community partners. So what I'm inviting you to do is, as we go through the presentation and I talk more from a healthcare perspective and some of the background, I'm hoping that you folks all, as people who are deeply embedded in in mediation and decision making, will start to imagine this from your framework and from your perspective and see where the congruencies are. So so we'll just move to the next slide. What we're hoping to cover today is a little bit, as I mentioned, about what is shared decision making, and we're going to take that starting sort of from the health care perspective. I'm going to go over a little bit of the context and evidence for shared decision making. At that point, handing it over to Bonnie to talk, really about the process. What is decision coaching, and what are decision aids, and how do we actually operationalize this? And then to Kim to really talk more in depth about our ongoing partnership together. So if you can head to the next slide. So shared decision making is really a process that all of us do, as I've already mentioned. I think this, this idea of bringing people to a focal point or a common area around decision making is something that's, that's critical for all of us, not only in our daily lives, but personally, but in our professional lives. And but what we're often surprised at is that often people don't take the time to bring actual structure to decision making, and shared decision making is the process that allows us to do that. And in healthcare, what we see is this is a structured process that allows us to work through a decision in a stepwise way, taking into account really two main factors. One is the best evidence. So really, what are the foundations of the decision pathways, and what are the risks and benefits of each of those? And then, really matching that with patient values and preferences. And when we do that in a more structured way, we clearly overcome a lot of obstacles, and it really leads to improvement in how we journey on a healthcare pathway with patients and families. So if we can go to the next slide. How we adopted this really is through a series of decisions to in the context of shared decision making that demonstrated our commitment to a number of principles, and of course at the top of that was everything we do in Children's Hospital is a commitment to patient and family centered care, or what some people may say client and family centered care, and we really feel that being involved in a meaningful substantive way in your decision making is really probably the most critical patient-centered activity, that we can do. I always say we spend a lot of money on, making things look child-friendly and family-friendly and signage and that sort of thing. But until we actually bring patients properly into, the actual.
It also looks like a derp.
Making, I'm not sure we've achieved true patient-centered care.
Can we try this again?
Hang on, I'm just going to mute all for a second. And Craig, I'm just going to unmute you in just 1 second. I just have to find you again. Okay. All right, Craig, I've asked you to unmute so you can unmute. There was just some, funny conversation.
No problem. Thank you.
Thanks.
So, of course, we also are always trying to achieve, evidence-based care and give patients the proper treatment options and allow them to evaluate the benefits, drawbacks, and clarify their priorities. And similarly, this is really a, shared decision-making, a two-way street. It helps physicians and healthcare practitioners to actually take time to really come up with the evidence in a more structured way, and that's important to avoiding scenarios where things go sideways in terms of ethical or legal challenges, and often that's rooted in this busyness of modern healthcare, unfortunately, with everyone feeling time pressures to see patients and move through the care process. So this helps alleviate some of those tensions as well. And then, what I'm really excited about, and partly that's why we're here today and seeing some of the fruits of this in terms of spin-off, is I think it ultimately helps support people who have gone through the shared decision-making process to build patterns of healthy decision-making that then they can apply to other areas and over time. So if you can just move on there, Marianne. Mm-hmm. And so as you'll see, I'm painting the picture here of bringing healthcare providers who are the expert on disease and have the experience of treating many people and having the healthcare literature more proximal to them to help make decisions, and the patient who's clearly the expert on the patient and what their preferences are. But unfortunately, we sometimes slip into archetypes that aren't as healthy for the decision-making process. And if you can advance there, Marianne, these things would not be unfamiliar to you. And I'd invite you again, as people who are making decisions and helping people make decisions, to think about sometimes the things that you morph into that are less helpful in making the decision. And so, those are things certainly on the healthcare provider side, like being overly paternalistic, flooding people with knowledge. Physicians are very good at that, often giving all sorts of, high level stuff that people can't necessarily digest. Drifting away from the evidence for various reasons, being too busy and disengaged. But the same kind of things can happen on the patient side where, maybe people aren't always bringing their best selves to the decision making, so they're ready to just give up control. We hear a lot of that, oh, whatever you think is best, doc, or, leaning a little bit away from making collective healthcare decisions like anti-vaccination, things like that. And of course, patients now have access to tremendous amount of knowledge and often get sort of caught up in having difficulty sifting through what is higher levels of evidence and around decisions. So in this context, you can see where making structured decision-making pathways can be very, very helpful. And this is only a kind of a brief picture of, all the various obstacles that we can encounter. If you can go to the next slide. So because of this, shared decision-making has really started to be at the leading edge of how we're best to make our decisions in healthcare. And not only have we seen an exponential rise in evidence in the healthcare literature around shared decision making, but we're also seeing it now start to creep into care guidelines. And I've given here 2 examples. You know, the new breast cancer screening. You know, right in the title, they put, you know, shared decision making as the paradigm for this, and the new ADHD guidelines from CPS, you know, also mention shared decision making as the approach in which the guidelines should be carried out. So if you can go forward. I also just want to briefly put this up, and you can, I'm not going to read each of these statements, you can look at these as we go, but just want to say that that there's very much evidence for shared decision-making environments, shared decision-making tools, and shared decision-making coaching that's in the literature. And one of our sort of higher level evidence-based structures, platforms that we use are these Cochrane reviews. And certainly there's been a healthy amount of Cochrane reviews that have summarized the evidence and show here that really for patients, healthcare practitioners, and health systems, that shared decision-making lends to, you know, numerous benefits. If you can head to the next slide. In pediatrics, though, we have a little less of a robust literature, but we do have some. I go back here again to a systematic review, which was well done by Wyatt, and took a number of pediatric studies and summarized the data. This was, sorry, the PDF I'm seeing, at least on my screen, doesn't come through particularly well, but in this table you'll see a typical systematic review diagram, and in this systematic review the authors took all studies that they found related to pediatric shared decision making. They ended up being able to use 15 of the studies, sorry, it's cut off there, for analysis, and the value of this is they included observational and randomized controlled trials. And I'm just going to show you 3 results. If you look down at the bottom of the slide, this graph represents the evidence for shared decision making interventions having an impact on decision satisfaction. And as you can see down here, the very bottom diamond is to the right of sort of the null line, and that's suggesting that there was a trend here. It just crosses, so it wasn't statistically significant here, but it's certainly a strong trend that decision satisfaction is improved with shared decision-making modalities. If you can go to the next slide. Similarly, same setup here, same systematic review, this time looking at studies that had evidence around decisional conflict. And here again, if you go down to the overall meta-analysis, you'll see at the very bottom, the diamond, quite a tight confidence interval here showed that there was reduction, statistically significant evidence of reduction in decisional conflict. And then if you go to the next slide, and here, this graph represents improved knowledge of the decision. And again, to the right of the line now suggests an improvement on that outcome. And again, that was an important and statistically significant outcome here. So we can see from this study, putting together the literature as of 2015, we do see benefits in multiple areas of decision-making when you use structured shared decision-making process. If you can move to the next slide. So I'm going to stop there, having given the, sort of the background, and now hand it over to Bonnie to, kind of walk you through exactly what, what she does and how we operationalize this. So thanks, Bonnie.
Thanks, Craig. That was set up really nicely for me. What is decision coaching? And I'm sure that all of you have some idea of what decision coaching is. It's been used for quite some time. I think you look in the literature, sports fanatics use decision coaching for professional players. They use them in universities. They've used decision coaching, but we're using it here from a medical perspective. And it is a structured approach, and it is, I am outside the circle of care, and by that, that means that I'm not involved in the discussions that the healthcare provider has with the family, so that I'm not influenced in any way. So it would be the same with the London Family Court Clinic, is that I'm not a part of any of their discussions. I'm outside of that conversation, so I bring nothing. I don't bring that in. That information does not come with me to the consult. So I'm quite neutral in that regard, but I do get the information from the whether it be from Kim or Dan or Peter, some background information. And in the hospital, I do get the information from the primary care physician. I need to know what the diagnosis was, what was presented to the family, so that I can gather the decision, what we call decision aids. It's supportive information that's tailored to their particular recommendation of what the physician or the healthcare provider is recommending, so that I can be clear when I'm sitting with the families, what are the benefits, what are the risks, and what are their options and how they value those options. I'm not there to make a decision for them. I always explain to the families that it doesn't, I'm a neutral party. I'm there to help facilitate and give them the tools so that they can make the right decisions for them, so that there's no regrets at the end. And also that it doesn't really matter to me what decision they make. It matters that they felt that they had appropriate facilitation, and that they came out with something that was appropriate for them. It's also important, I always tell the folks who refer that that the recommendation you make may not be their preferred decision in the end. So there is a risk involved here, that the outcome may not be what you're thinking, but it's based on what they feel their options are and how they value those options. And so I usually do them face-to-face. By telehealth, I'm using remote right now, conferencing because of COVID, but we're finding that the teleconferencing is working out quite well, and will probably continue whether it's with COVID or not. But some families prefer a face-to-face when they have a tough decision to make. They want to see a live person. They have told me that, but they do recognize that that's not possible at this particular point in time. So if we go to the next slide, just to show you what type of decision aids, what I call, or what we call decision aids. There are different levels of decision aids, but you can I can give them to the families in print. I can refer them to a DVD or video. There are videos and DVDs for some of the healthcare diagnoses that are out there. Not a lot, but there are a few. And sometimes the DVD is not necessarily tailored to what their recommendation is, but it gives them a sense of what that looks like and gives them a better understanding of the diagnosis. And of course, online computer-based decision aids is where we get, where I pull and where the families pull information. I always encourage them not to go to Dr. Google, but to really use the aids that we're presenting to them, because they are tailored to what their issue is. And many times on Google, as you know, it can take you to a different place, and by the time they get to me, their level of conflict is extremely high. So if we go to the next slide, I'm just showing you an aid that is a confirmed decision aid from the Ottawa CHEO Children's Hospital. It is a validated tool, and it's an excellent tool that I give to the family so that they can continue to use this tool for additional decisional issues or conflicts that come up. This is an example. You can see it's pretty small print to read just from here, but in your own time, if you want to look at the slides again and enlarge it, it does provide on the left-hand side, you can see where they are given how many options are there. Is it to take the recommendation and look at the benefits and risks of that recommendation, and then what are the reasons that you might avoid that option, or is the option not to do anything, to continue on the status quo, or is there a third option that you're coming up with that's a mixture of both that they think would work based on the information that we've talked about. And you can see you look at identifying their knowledge level, if they have sufficient knowledge. If they don't have sufficient knowledge, it's very difficult to make a preferred decision. You have to make sure that the families know give them the information that they need to know so that they can determine what is best for their child. And many times it is the families, it's the parents that I work with, because the child is not able, either isn't old enough or is not able to be part of the discussion. And sometimes I do have a few children that are like in 14 to 16, 17, and then after from 17, 18, they start to transition over to the adult world for decision making. They move from pediatrics. And then, how they value, you can see on the second page there at the top, their values. And do they have supports? It's very important to know if families have support, whether they're working on their own, making their own decisions. Do they have friends or close relatives? Do they have a support group network that has a similar issue that they would like to talk to someone else, another family that's had a similar experience? And then how certain are they about the decision that they're making? And the rest of the tool goes and clarifies sort of some points about what you would talk about and what the families need to talk about and consider in terms of their values. And so this tool is very key for them, so that if they get into another position where they're trying to make decisions, especially with separated families, they could pull this tool together and sit down, or try to sit down or have a conversation about, go through the same principles, go through the same steps. What are your options? And be able to talk to one another about what knowledge do they have? Is it the appropriate knowledge? How do they value that? What supports do they need? Are they really certain, and come out with a preferred decision? And with, of course, with some of the COVID families, which we've only had a couple of cases so far, but with the families that are separated, whether it's medical or through the family court clinic, bringing those two parents together is one step in working towards a successful outcome, getting them to talk to one another, getting them to listen and appreciate what each other's opinions are, what the options are, what the evidence is, so that they can make an informed decision. Go to the next slide. I'm watching my time here as well. Just wanted to Craig had mentioned at the beginning, we've been in operation for a couple of years now. We're into our third year. And since we've began, of course, our referrals have been medically oriented, the 100 referrals since implementation. They're complex, they're not always straightforward. Sometimes it's about families who are just trying to decide on whether to go with a particular choice or not go with a particular choice, whether it's an NG2 placement or a G2 placement. They just can't decide, and they can wait up to a year before they can make a decision. But with a decision coach now on board, we can move this forward a little bit, have a little more efficiency in making decisions. Sometimes there's multiple healthcare providers involved, and they express differing opinions. It's very overwhelming and confusing to families. They have a tough time with, this physician said that, this physician said this. My therapist said this. I don't know what to do for my child. And then, of course, the households were differing opinions and treatments. And when you get the two families together and they sit and they're able to talk about their thoughts and their options, many times they say to one another, I didn't know you were thinking that way. I didn't know that you felt about it that way. And that makes a big difference in terms of the communication. And it's all bottom line communication. And although within healthcare, even if they are living in the same household, many times people just get involved with their day-to-day life. if they have children, they're working on right now, it'd be school and whether to go to school or not, or, you know, who's going to get the groceries, who's going to taxi this child here or that child there. And they really never sit down and say to each other, this is exactly what I'm thinking. This is what I feel. This is what's important. And having someone like myself, a third party who's not involved, who comes with kind of a clean slate and doesn't know all the background, they feel safe, interesting enough, to talk about what it is, how important it is, and they can tell each other that when they're sitting together. And it makes a really big difference when you get to a preferred decision. And of course, I work with families who have language barriers where you have to bring in an interpreter. And so the examples are just some of the examples that I've of the cases, and with Dr. Campbell's assistance, this has made a big difference in pediatrics. So those are just some examples of situations or cases that I've worked on. If you go to the next one, I don't know, Kim, do you want to talk about this, or do you want me to introduce this? Kim?
Sure, Bonnie, you can introduce it, and then I
Okay.
can carry it on from there.
All right. Or Craig, did you want, maybe you want to talk about the partnership?
Oh, go for it, Bonnie. Yeah.
Okay. With the partnership that we have, and Kim's going to talk a little more thoroughly about it, and then Craig's going to come, I think, back into the end of this piece, is that it is a relationship between LHSC Pediatric Shared Decision Making Coach, the Children's Hospital, and the London Family Court Clinic to support separated families with COVID-related parenting decisions. And it is a special program because it's supported by the Government of Canada's Emergency Community Fund, Support Fund, and Community Foundations of Canada, which we're extremely appreciative of. And it wasn't for their supporting, we would not be able to provide this support free of charge. So we're making you aware of the program so that you can refer patients and families if they're experiencing problems with any form of decision making related to COVID for school. And then the next slide.
Sorry, making notes.
It's okay.
Okay.
We did get, thanks to Peter Jeffrey, Dr. Jeffrey, we did get some media attention. And there was an article from Randy Richard within our London Free Press, and he did a great job, interviewed Dr. Campbell and myself. And I think Kim was involved in that interview as well. And so I just bring it to your attention to show you if you missed it or you wanted to go and take a look at it. It's quite an in-depth discussion, and talks about how families are preparing in with the pandemic and endless decisions that they have to make. So it was well done. We also had an interview on 980 AM, which went fairly well as well. And it was put on global news so that people could hear about it as well. And then we'll go to the next slide. I'll have Kim take over the need.
Okay, great. Thanks, Bonnie. So as most of you on listening in today, the London Family Court Clinic works with parents making decisions every day, whether it's through mediation or parenting coordination or helping them through conducting a parenting plan evaluation. And what we were finding is when the pandemic started, families were really struggling with this additional piece in terms of sharing time between households. It's very complex when you have two households, and so much bigger and multiple social circles for these children as they transition from home to home. And parents were really struggling with that. You know, either they had a lot of anxiety, health-related anxiety, or you also, of course, you know, many of you work with parents who might use that to leverage their position in terms of making parenting time decisions and deciding on parenting responsibilities. So we had a lot of families who were currently trying to make family decisions, but we also had a lot of families who had been away from us for some time and seemed to be doing quite well, and then came back because, you know, while they'd been making decisions fairly well for their family, they're really struggling with this particular this particular decision in terms of school or sharing parenting time and those kinds of things. So, you know, we're really looking for a way to help these families, and we're really excited about the shared decision-making work that was going on at Children's Hospital with Dr. Campbell and Bonnie. Two aspects of it that we thought were really well suited to our families were that, first of all, you have this medical expertise or credibility that you can bring into decision making for these families, and they really respond to that. The health information about COVID is very confusing. You have a lot of different organizations saying different things, and it's really hard for parents to make sense of that. It also changes over the course of the pandemic as we learn more about COVID-19. So bringing in that medical health expertise really does lend credibility for these families, and a trust that's there in terms of making decisions that are best for their children. The other thing that we really appreciated about the process is that, you know, historically, we may have worked with families in parenting coordination. You know, essentially in parenting coordination, you want to work yourself out of a job. You don't want to be a family's parenting coordinator forever. You want them to be able to take on that decision making themselves through some of the education you do with them. And then so to have them come back, we didn't want to take that back from them. We wanted to empower them to continue to make their own decisions for their families. And so the shared decision making really does you know, keep that empowerment within the family, and helps them move forward in a way that that is really in the best interests of families in general. You can move to the next slide there. Thank you. So the way it works from LFCC's perspective is that referral comes in to the clinic, and the family has to have an existing parenting plan agreement. So something they've either, you know, decided by themselves at the kitchen table and have written down and have, you know, been working on for a while, or it's through a mediation process or through a court order. Both parents, of course, have to agree to the referral. And then we spend a bit of time doing an intake with the parents. We need to screen for domestic violence and power imbalance, of course, to make sure that the process is safe for everyone. You know, if the families haven't been involved in, you know, a court process or a mediation process for some time, we all know that safety and risk can change as, you know, as families mature and things like that. So we certainly want to make sure that we cover that off to make sure that everybody's safe. And then we narrow the issue. Sometimes families come back and they have a medical or health related decision related to COVID, but there might also be some other things that they want to squeeze in there. And so we really want to bring it down to a single issue, medical or health related, COVID related issue that we can send along to Bonnie. So she's not, you know, having to manage all of the issues of the family, but this particular issue in particular. So the intake will narrow the issue for the decision coaching, and then we refer that on to Bonnie, and she does her wonderful work with the family. You can move along there. The next slide. So this is just a summary, and this was in some of the information that went out for this webinar, but you know, you're welcome to take a copy of it as well to share with your clients, and to make a referral. The information is there. I think we have that on the next slide as well, Marianne. Thank you.
I thought it was 2.
Yep. So, yeah. So just
the
to
right
wrap
one?
up. Yeah, that's okay. Yeah.
That's
Just to wrap up.
Yeah.
Oh, go ahead, Bonnie.
No, I was just saying it's coming up after this slide.
Oh, okay. Okay. So yeah, in terms of the roles, so then when the information comes back from Bonnie and the family has had an opportunity to do their shared decision making, then the London Family Court Clinic will write a brief report, just explaining what the process was, what the outcome was, and then where appropriate, we'll include some resources for families. So we had a family where hugging was a bit of an issue. They were really struggling with the child hugging different people, and so actually the New York Times had a really nice article on how to hug safely during a pandemic. So we were able to share that with the family and, you know, put some ease around some of those pieces, and they had something tangible to take with them to refer to. All right. There we go. This is the referral information. So it was in that nice graphic that you saw before, but it's also here as well in terms of the phone number and the email. Great. Okay, so Bonnie or Craig, I'll pass it back to you.
Bonnie, do you want to speak to the case, some of the cases you've done, or some of the issues you've come across?
Right. There have been a couple of COVID, and there was another case from the London Family Court Clinic that was medically oriented. It wasn't a COVID issue, but the cases that came forward were obviously of separated families who were trying to, it was about accessibility of their children through COVID and wanting mom to be a little more, I guess, release the children to the father, and being able to talk through why it wasn't talk it through with each other. They had what came down to was, because the families were separated in the cases that I had, each had new relationships, and those relationships had children. And so what would happen is the bubbles, as you know, the concern with the mother who had the primary care of the children didn't have information about the new spouse or the new the father's new relationship and where those children went and who they saw and anything about them. And so mom was always careful about wanting to find out more. And of course, you know, I know Kim said they try to not send those cases where they're bringing all their past history and their issues forward. However, they do bring them forward to the cases because that's the grounding of how they got to the place they are. And the fact that we have those tools that I shared with you to keep them focused, take a structured approach. This is what we're looking for. This is what my role is. And this is in the best interest of your children. So once you get them focused on, it's not about them. It's about the reason they're struggling to make a decision. And here are the options. Here's the evidence. Here's what it says about COVID. Here's what it says about accessibility and where they can go and what they can't do. And it's important to talk about what's happening in their region. As you know, each region is a little bit different in terms of the restrictions. So I have to have information on that, but families are, most of them are up to date on that. The two cases that I did have on COVID went very well, actually. Once we got through the muddy waters of why they were upset with each other and focused in on the children, we were able to get to a preferred decision of looking at access for the father and the frequency of that access and what the conditions were, and they both agreed with it. Were they terribly happy with it? Probably not the best scenario, but they were happier than when they came into the consult because they had a response of seeing their children again, right? And so there was another case, I don't know if you want to talk about it, Craig, more, the medical one that, because you talk about it fairly well about the case from Family Clinic.
I mean, just in, you know, in general, you know, obviously there's kids with medical complexities as well that are, you know, sort of struggling with, you know, ideas about how to access care and navigate the system, often, you know, traveling. So, you know, there's decisions to be made about, you know, whether it's worth coming to the hospital via, you know, a plane ride from up north, given a medical condition, or whether, you know, a compromised virtual visit with local blood work or something like that can. So these are also, you know, decisions for the kids who do have, you know, medical diagnoses. You know, how do we help them navigate the, you know, the system during COVID safely? And it's amazing, you know, just how people's people's risk estimation can be, challenging. We had one family who, were happy to put their kid, on a plane through airports, get here, to avoid their description was they wanted to avoid going to a local blood lab. So again, to me, the risk of going through an airport and sitting, in a 1 hour flight, or whatever it is much different than going to a local blood lab and getting your blood taken with the proper precautions. So, so these are the kinds of things we try and help them work through. And I like the way Kim said it, we bring perhaps some credibility to the discussion, but I mean, I think it won't be lost on anyone on the call that the data around, COVID in children, risks are really shifting quite a bit, so much so that it is quite challenging for us even to sometimes articulate, what those risks are. And I think it's often just helpful sort of acknowledging that, taking, walking through. But I think it does perhaps help that, that there's a medical framework around it that does provide some comfort. And of course, we do have close contact and can bring in people like infection control, infectious disease physicians who are, part of my department to help put some meat on the, on the skeleton of the decision, if you will. So, so this is, just gives you some flavor of how we handle those.
I think that was really important what Craig just said, that, you're not working, we have this program, but we're not working in isolation. Like there's a whole, well, I would call like an army of people who have a specialty in all these areas so that you can go and get the most up-to-date evidence and the information so that when you're working with the families, you have these facts so that they can make informed decisions. So that's the advantage of inside the Children's Hospital, is having these experts sort of at your fingertips.
Do you want questions now, Bonnie, or are you?
Sure, unless Kim wants to add anything about any cases or recent.
No, I think we can take some questions now if anyone has questions.
Okay.
Thanks,
I think, as I'm listening, I'm learning, and I'm really, there's a lot of us as family mediators write what's called the dispute resolution clause into our agreements. And so that generally says something in my MOUs, at least, that the parents consult with an expert in the area of the dispute. And, I've often given examples such as teachers, principals, universities, like any sort of information, but this sort of expands that thinking. I didn't recognize that there were these types of resources available to families. And I think that you're bang on when you're talking about the fact that there are, that making good decisions medically makes, the family feel stronger and safer and be able to make other types of decisions in a more collaborative way. So I think it's just really neat to hear that this is available. Is this a common, like this type of coach, is it common outside of London Children's Hospital, or is it specific to just London?
So to our knowledge, we're really the only children's health institution that's providing an active shared decision-making coaching service in this manner. There are, other children's hospitals who have engaged in and invested in shared decision-making paradigms, but they often might be more of a, say, a toolbox or training people who are already on the healthcare team to sort of deliver and be able to move in and out of the treatment team or the recommendation into a coaching modus operandi. But we felt when we launched the program that having someone who was outside of the circle of care would bring a level of impartiality and reduce the bias. And that has been demonstrated in the literature when you embed shared decision-making, actually say in the treatment team. It can sometimes be hard to, to switch very quickly from, this one paradigm to being a more impartial guide through the decision making. And patients say it doesn't always, work that way. They still feel some of the bias. So this has been very successful for us and has been able, partly because of this, has allowed Bonnie to develop a skill set that is relevant to things that happen outside our four walls as well.
I was thinking Bonnie is, doing mediator training on site there, right? I mean, it sounds like you're, London Family Court Clinic.
Take my advice, though. He doesn't.
Yeah.
But you know what? That's the other thing I should mention. We're not here to, some people always say, well, hang on, I'm doing shared decision making every day. And in fact, we recognize that, and we don't want to be presumptuous to in any way say that, what we're doing is something that can't actually be done, and is being done. Elements of it are being done. What we have found, though, but by really naming it, putting a structure around it, and and adhering to shared decision making in its strictest sense, it really does allow for people to overcome obstacles that they're getting into with families. Even if you're the best mediator or the best healthcare provider, there are times where you will struggle and stumble with families, and that's where it can be good to bring some in. There's also, as we've talked about, vulnerable populations that that this really benefits. And we didn't go as deeply into that, but families where there are strong cultural beliefs, where there are need for people beyond, who aren't as autonomous in our Western culture, like they like to have lots of people involved in the decision. Those kinds of things don't often happen in a typical physician's office, right? So this helps. And, and again, it can be, it doesn't always have to be big, complicated decisions. It can also be simple decisions that families are making big and complicated. So we really, want to appreciate that there's a role for it in all these dark corners where, where shared decision making, if you have a feeling that the decision making is not going exactly right, that's a time to think about a shared decision making consult.
I think it's really neat. We've got a couple of comments and questions here I'm just going to read. So Julie likes the structure, and naming it really does make a difference, she feels. She's saying this is a wonderful collaboration, kind of used in elder mediation world, but really needs to be expanded. And I think, so OAFM, we've got child protection mediation, family mediation, separation, divorce, and we have elder mediation, which is multi-party intergenerational family mediation, where there's a lot of healthcare decisions. So I think she's relating the child shared decision-making to the adult child, senior decision-making. And I think she's absolutely right. There's probably a need for this to be expanded in so many ways. Okay, so then the second question, I think, is just a comment for me for later. And another person coming into the room. It's a busy webinar. There's lots of stuff going on. When you were talking about some of the issues that come up, the one that does tend to come up a lot for our mediators are gender issues. And it's hard because as a non-medical professional, you're trying to hear people discuss things like, the use of hormone therapy, starting hormone therapy. One parent says that can be stopped and rewound fairly quickly. What's the other parent so worried about? And, I think that piece is often something that, I, as a mediator, and I know my colleagues search for, what is the information that I need to know about this? And just the idea of acceptance of change in gender is something that we deal with quite a bit. Have you got any advice for us on how to talk to parents about that type of particular decision? And it's not the parent's decision, is it? It's the child's, but the parents have to enable a wee bit there.
Yeah, that is a very complex decision, obviously, and we recognize that within Children's. We have started an initial partnership with our gender identity clinic, and so Bonnie's gaining some experience in those kinds of complex decisions. But again, the good news about this is, Bonnie does have the resources behind her. We have a clinic, a multidisciplinary clinic that deals with these issues, and so she can draw from that, for families that would be coming to you, draw from that expertise, really use that to generate the pros and cons. And so I don't want to speak directly for you, Bonnie, but I think that would be something that you would feel supported by our internal expertise to be able to sort through a decision of that nature.
Absolutely. We do. There's an amazing team here at Children's, and we have been working together, but these situations don't come up very frequently. So there's not a lot of cases that they do have a strong team, but there is a role for a decision coach such as myself in that team. But as I mentioned, there's not as the opportunities don't come up. They're not a large number of them, but I would feel very comfortable. They would be very helpful to me in a situation should you make a referral of that.
And again, just to be clear to everyone, when we say that, we're not talking about having the child see a new team of doctors, but what we do is try and take the decision they're grappling with and bring all the evidence together. And you've seen the chart that Bonnie put there. We really spend a lot of time populating the risks and benefits, trying to make sure the knowledge is correct and evidence-based, and that's where we can draw upon the experience. Sometimes we have to go outside. We go and consult an orthopedic person from another site or someone who has the expertise. So it's all really about generating that first evidence map for them, so that they understand really what they're making the foundation of the decision around, and then we layer on the other pieces.
Yeah. Sort of, I mean, it sounds like you're doing what we do as mediators, trying to bring in as many experts as we can. And if we don't know the answer, we're encouraged by our standards of practice to sort of bring in other people. Back to COVID for a little bit. So this program can look at any shared decision-making related to COVID. It doesn't have to be, it could be anxiety related. It could be mask to mask or not to mask. Pre-grade 3, I understand that parents have to make that decision, right? Is that, what does London Family Court Clinic do with those referrals? Can they come in from across Ontario? And when do you decide to put it through this program in particular? And I guess that's a question for Kim and Dan.
Yeah, I mean, I think if the issue is COVID specific, and because we have a grant now to offer the service free of charge to families, then we do try to leverage that for them so they can, have this opportunity without having to expend a lot of financial resource at the moment, which I think is really beneficial. So any COVID, so we've had, questions about school, whether they should send this child to school or whether this child should go online. We've had questions about sharing parenting time and whether it should, stay with the agreement or shift. And there's a lot of complexities in that, in terms of the social circles and bubbles of the child. If one parent is a healthcare provider or in a really high risk job, does that change or increase the anxieties, and how does that play out? I think the other wonderful thing about shared decision making is the parents, we talked about this a little bit, but they really do develop some skills in the process and have some tools that allow them to, transferable skills, I guess, in terms of making other related decisions as well. So that can be really helpful.
Yeah, I think that's what the research that Craig was showing us, is that sort of extrapolates. If this decision is made well, it can just, you know, build on itself, which is nice to see, right? I'm not saying I understood the statistics and the charts and the outlying data, but my son would understand that. So
Yeah.
I was
So
smiling when I saw
I'm
it.
just going to jump in here for a second. Marianne, thank you. Thank you everyone for the presentation. The piece that I think is really important to recognize is that many of us have gained some skills over the past several months in terms of the operating virtually, being able to respond to families at great distances, and being able to offer services such as this in a manner that is workable given the COVID and the pandemic circumstances. So using OTN, using different virtual mediums to facilitate the work that can happen, and keeping it focused and brief in that manner, I think is also appreciated by families, and not long wait lists, that kind of thing. So thank you.
And so and just to sort of, like, people say you live in Toronto, you have a family that lives in Toronto, there's a COVID related area, they can contact the London Family Court Clinic, or is it, yeah.
Yeah,
Okay.
so we've
Yes.
had out of London families
Yeah.
Yeah.
Okay.
do this.
Okay.
Yeah.
That's good. I mean, that's good to know. And how long do you expect this program to be able to run for based on the current grant? Do you know?
Well, the current grant ends at the end of March, but I mean, I think we're hoping that this partnership will last for a very long time, and we've certainly endeavored to seek out more sustainable funding, and we'll continue to do that.
Yeah. That's terrific. I think it's definitely one more tool for us to think about, right? And to do this. So a question, what's the level of uptake so far? I think there was about 100 cases so far that you've done overall. Is that through this grant, or is that since the program started, Bonnie?
Since the program started.
Yeah.
With the London Court Clinic, I think we've had about 3 or 4 cases that have come forward. A couple of them were COVID. The others were medically related. Yeah.
Okay.
The partnership is very new, and the funding is very new. So we're
Yeah.
just kind of starting it out,
Yeah.
which is exciting. Yeah.
So it means that there's, for people who are listening, that there's an opportunity for actual referral with a shorter waiting line potentially.
Yeah, I think we want to turn them around very quickly, because health
Yeah.
and medical related decisions, you want them to be timely, essentially, right?
Yeah.
Yeah.
And the connection to you, there was a phone number somewhere, but is that how the mediators would contact you?
Yeah, so in the slides, there was a phone number and an email, and they can reach out and start
Okay.
the process of referral, certainly, yes.
Okay. And so anyone can on here can just email me, and then I'll make sure I get that information to you. And the slides are okay to share? I should have asked that before. Okay.
Absolutely.
Okay.
Yes.
For sure.
All right. Yeah, well, that would make it easy. So if anyone wants that information for a referral, just let me know, and I will send that on to you. Just email me. There's tons of people on here, so I'm not keeping track, but we're coming up to 2:00, and I just wanted to say thank you so much for, first of all, taking on this initiative and really seeing the need, and thinking about joining together. I think is where we make some of our strongest partnerships. Really, is when we think outside of what we do and we work and reach outside to each other and share expertise. So I really wanted to thank you for doing that, first off, and also to thank you for thinking of OAFM and sharing your time here today and doing this great presentation. I really, really appreciate it. And I know that there's like 44 people on, will appreciate that too. So thank you very, very much.
Thank you
Thank
for
you.
having us.
Yeah,
Really.
Thank
you're
you.
very welcome. Yeah.
Thank you.
Okay. Take care. We'll talk
Have a
again
good
soon.
day. Bye.
Thanks. You too.
Bye.
Bye-bye.